Hyphema, or blood in the anterior chamber, is one of the most common sequelae of blunt trauma to the eye. The hemorrhage is caused by a tear of the iris tissue and/or ciliary body during injury, and occurs at the anterior aspect of the ciliary body in 71% of cases. Patients with hyphema typically complain of decreased visual acuity, pain and photophobia. The diagnosis is made by direct visualization of layered or dispersed blood in the anterior chamber. A microhyphema occurs when there is no layering of blood, but red blood cells are seen within the anterior chamber. An 8-ball hyphema is the result of a large amount of clotted, deoxygenated blood in the anterior chamber, which has a purple-black appearance. A useful way for the examiner to monitor the hyphema is by measuring its vertical height of the layered blood. This measurement can be repeated at each follow-up visit to monitor for resolution. Secondary hemorrhage, or rebleed, due to lysis of the previously formed blood clot typically occurs between 2 and 5 days after the initial injury in 25% of patients with hyphema. A rebleed is signified by an increase in hyphema size and is associated with an overall worse visual prognosis. Because hyphema may accompany severe injury to the eye, a complete examination of the anterior and posterior segment is essential in order to rule out associated injuries and globe rupture. B-scan ultrasonography is often necessary, as the posterior segment may be obscured by blood, and a CT scan of the orbits may be indicated if the suspicion for open globe is high. Gonioscopy should be performed to evaluate the extent of injury to angle structures, but is usually delayed until after the high-risk, rebleed period. Anterior segment October may be useful in order to visualize the anterior chamber angle without direct contact. Elevated intraocular pressure occurs in 32% of patients with hyphema, and patients with pre-existing glaucoma are at an increased risk. In the acute period, elevated intraocular pressure is the result of red blood cells and fibrin blocking the trabecular meshwork. Persistent inflammation, resulting in peripheral anterior or posterior synechiae, can lead to angle closure glaucoma and can be prevented by administering topical corticosteroids and cycloplegics. Optic nerve damage, resulting from an acute rise in intraocular pressure, is most likely to occur if the intraocular pressure remains 50 mm Hg or greater for 5 days or 35 mm Hg or greater for 7 days. Therefore, medications may be required to control the intraocular pressure. Anterior chamber washout or surgical evacuation of the hyphema may be indicated if the pressure elevation persists despite medical management. Special consideration must be given to patients with sickle cell disease, as the sickle-shaped red blood cells cannot effectively pass through the trabecular meshwork, leading to higher intraocular pressures for longer periods of time. Sickle cell disease also poses an increased risk of optic atrophy, which can occur with intraocular pressures less than 35 mm Hg. It is essential to obtain a sickle cell prep and hemoglobin electrophoresis in all patients with hyphema, as sickle cell patients may require an earlier surgical intervention. These patients are typically advised to avoid carbonic anhydrase inhibitors to reduce intraocular pressure. Corneal blood staining occurs when hemoglobin and its breakdown products deposit in the cornea, resulting in stromal staining and endothelial dysfunction with subsequent vision loss. It occurs in 2 to 11% of patients with hyphema and is most common in cases of total hyphema, elevated intraocular pressure, rebleeding, and in patients with prior endothelial dysfunction. Early signs of corneal blood staining, such as yellowish discoloration and granules in the posterior stroma, are important to recognize, particularly in children who are at risk for developing amblyopia. Anterior chamber washout may be necessary to avoid this complication. Clearance may occur without intervention, but it starts peripherally and moves centrally with complete resolution taking up to several years. Corneal transplantation may be necessary for a more rapid visual recovery.